And I'm going to focus on motivational interviewing and treating alcohol problems, although as you'll see, it's now very widely used in many different fields. But I want to tell you how it developed outside the laboratory, as was just being said. And one of the first accidents was that I was in training as a psychologist to be a behavior therapist. But in the second year of our graduate training, there was a year-long course on how to talk to clients. And none of the behaviorists wanted to teach it. So they went over to the counseling program, and they found an academic grandchild of Carl Rogers named Susan Gilmore, who had studied with Leona Tyler, who had studied with Carl Rogers. And she taught us the person-centered way of being with clients, which is one of the most important things I learned along the way. Then I had a summer internship in Milwaukee, Wisconsin, my first exposure to alcoholism. And the director of the unit said, "What do you know about alcoholism?" And I said, "Nothing, really." "Well, what did they tell you in graduate school?" I said, "Well, I don't remember it ever being mentioned, you know." He said, "Well, this is the most common disorder you will encounter in your life, so you might want to learn about it." You know? And so I spent the summer learning there. And since I knew nothing, I simply put on my good listening hat that I'd learned through the Carl Rogers training and listened to patients. And they taught me about alcoholism. And I learned a lot, and they seemed to enjoy the conversations as well. Then I began reading the literature on alcoholism, and it said alcoholics are extremely difficult people. They are pathological liars. They're sociopaths. They're totally out of touch with reality. And the only way you can get through to them is just with a bulldozer, just really confront them and tell them what's real. And so well, that doesn't sound like the people that I was seeing. Maybe they're different in Milwaukee, I don't know. But it started a puzzle for me of how did we come to believe that alcoholics have all these pathological traits when in fact they do not? Yeah. Well, then I went to Eugene and began my research on treating alcohol problems. And in the second study that we did, we had a control group that was given a self-help book to go home and work on their own. So we randomly assigned people either to come in and see a therapist and get behavior therapy for 10 or 12 weeks, or to go home with the book and work on their own using the same methods. You know? And the question was, how much better will people do when they are working with a therapist? So they were randomly assigned to those two things. This is now the book that we used. We had in a very early form at the time, still in print. And to my shock and amazement, there was no difference in outcomes. That is, drinking declined very nicely in both groups, and if anything, a little more in the group working on their own, maintained nicely over a year, and there was no advantage in having worked with a therapist overall. I thought that can't be right, because I was taught the longer you spend with me, the better you will get, you know. So I went to Albuquerque, New Mexico, where I joined the faculty, have been there ever since, and I repeated the study. In 1978, same finding. 1979, same finding. 1980, same finding. People randomly assigned to self-help versus working with a therapist had the same outcomes. You know? But, well, it looks like we really have a finding here. What's going on? Maybe it's just the passage of time. Maybe when people come into a clinic, you don't have to do anything. They've already decided to change, and so they will. We also had people keeping diaries of their drinking and thought maybe that's it, because people told us when I wrote down every drink that I was having, I really noticed, you know, so we thought that was it. So we had a waiting list group that didn't get treated during the same time, but did keep a diary of their drinking. And what we found once again was the group working on their own with a self-help manual decreased at least as much as the rest. And the people working with a therapist also showed a nice decrease in their drinking. And those on a waiting list were very polite, and they waited, you know. And then they got better as soon as we could treat them, you know. Now, I found that several times, that if you put people on a waiting list, they don't change. Whereas if you tell them there's something you can do and here's some things to follow, go home and try this, you get a big change. And I realized the people on the waiting list were just doing what we told them to do. They were waiting, you know. They were very nice to us that they wouldn't get better until we could treat them. Then we treated them, and then they got better. So, okay. Well, now there are lots and lots of controlled trials showing that relatively brief interventions, 1 or 2 sessions, conversations, can bring about a change in drinking, even within the context of primary health care or other kinds of settings. So what was puzzling me in the beginning is now a very widely replicated finding, which I'll talk a little more about after lunch. But something else I noticed was that it made a really big difference who the therapist was. So they were all supposedly getting exactly the same behavior therapy. It was manual guided, so the instructions were there for the therapists. We randomly assigned people to the self-help condition or to treatment, and we randomly assigned them to therapists, and 3 of us sat behind a one-way mirror. We couldn't afford videotape at that point, you know, so we were watching our therapist work behind a mirror and rated them for how well they were doing the behavior therapy and also how well they were listening to their clients using the empathic listening scale that came out of the work of Carl Rogers. Then we got our follow-up data, and we lined up our therapists from number 1, the most empathic therapist, and all of us rated that therapist number 1 independently, down to the number 9 least empathic therapist, and we looked at their success rates with clients, and here they are. And it's not a random distribution. There are 2 with 100% success rates with their clients, and 3 with 75% success rates. Clients with therapist number 9 getting the very same treatment allegedly have a 25% success rate. If you average all the therapists together, you get about a 61% success rate, which is almost exactly the same as people going home on their own working with a self-help manual. And so you could come to the conclusion that therapists are no different from self-help, but you would be wrong, because we had 5 therapists here at least whose clients were getting better at a faster rate than those who went home and worked on their own. And we had 3 therapists where the client would have been better off going home with a good book, you know, and not sitting with his therapist. That has been repeated over and over and over again in the addiction field, that it matters very much who is delivering the treatment. In fact, we could predict 2/3 of the variance in drinking, that is, how many drinks per week are clients having 6 months later from how well the therapist listened. And even 2 years later, we were still predicting a good part of the variance in drinking, how many drinks per week are clients having, from how well their therapist listened to them 2 years ago. Big effect. I didn't expect it. I mean, this was sort of a side interest in this study, but it blew me away. With that, I went off to my first sabbatical leave in Bergen, Norway, worked in an alcoholism treatment hospital there. And one of the things I was asked to do was to have a conversation every couple of weeks with the psychologists there, most of whom were recently out of school and were treating people with pretty severe alcohol dependence. And the director didn't give me any particular assignment, just said, you know, get together and talk and see what comes of it. Well, they wanted me to demonstrate how I would be treating the clients that they were seeing. And so they would role play their clients in English, happily, you know, since I didn't speak Norwegian at the time. And then I would do my best to show them how I was working with clients. And unlike my American students, these Norwegian students interrupted me all the time. So I would be counseling, and then they would say, no, stop a minute. What are you thinking? I thought, well, it's an interesting question. Yeah. You asked a question, but you could have asked many questions. Why did you ask that question? You reflected something that the client said, but the client said many things. why did you reflect that particular thing? What are you thinking? What's going on? And they literally evoked from me some decision rules that I was using in working with clients, of which I was not aware. I was not conscious of what I was doing. And together we began to build a description of this way of working with people, the essence of which is that the person who should be making the arguments for change is the client, not me. You know? In fact, if I argue for change, the client argues against it. And they hear themselves arguing against it, and who are they going to believe? They believe themselves, all right? But if they can arrange the conversation in a way that they make the arguments for change, it seems to move better. And that's what I was doing by asking particular questions and by reflecting particular content. And be sure to evoke the person's own concerns and motivations. They don't care why I think they should change their drinking, but they do care about their own motivations. And listen with empathy. I was still doing lots and lots of Carl Rogers, what I had learned in my second year and practiced on that internship. So listening very carefully to clients. And if you meet resistance, don't push against it. Don't disagree with it. Don't argue with it. Don't try to talk the person out of it. But listen, just sort of flow with it, you know. This was very, very different from American addiction treatment at the time, which was highly authoritarian, confrontational. Shut up and listen. You don't know anything. You're an alcoholic. I know the reality. I'm going to tell you what reality is, and I'm going to tell you what you need to do. You know? Now, most human beings don't respond well to that. Yeah? Most human beings don't like being told what's wrong with them and given advice as to what they should do. In fact, the normal reaction to advice is to do the opposite, or at least not to do it. Right? Be sure also to encourage hope and optimism that change is possible, and it is with people with alcohol and drug problems. It's very possible. Yep. So they say why it's important. I don't get into power struggle arguments with them. I encourage them that change is possible. And I gave it the name motivational interviewing. I was trying to think what to describe this style as. And it was certainly about motivation. And I liked the word in English, interview, because an interview is a power-neutral term. You don't know who is the more powerful person in the interview. You might be an employer who's hiring potential employees, in which case you're the powerful person there making decisions about the other. But you might be a lowly college student interviewing a famous visitor, you know, in which case the power is the other way around. You can't tell from interview who's in power. And actually in motivational interviewing, there's equal shared power going on. So that's why I chose that term. I thought about motivational conversation, but in conversation, both people have the same role. They're doing the same thing, whereas an interviewer has a different role from the person they're interviewing. And I was thinking of this just as a preparation for treatment, not as a treatment itself, but as something that would kind of get people ready for treatment and help them respond better to it, which in fact it does, as you will see. So then I went back to New Mexico and began doing some clinical trials with this. Randomly assigned problem drinkers to get an immediate motivational interview or to wait 6 weeks, and then we would do the motivational interview, and the same thing happened. Absolutely no change in the waiting list, and immediate change in people who got one motivational interview. And it lasted well over time. And by the way, we found this several times, that if you make people wait for treatment, it doesn't hold as well as if you give them something right away. You know? So waiting lists are pernicious. Waiting lists are not a good idea. Instead, give people something right away that's likely to help them. No. Well, then I went off to Sydney, Australia on my second sabbatical leave, and I met a South African who was living in Wales but had been sent to Australia to do research. And his name was Steve Rolnick, and he had the office next to mine. And he said, Miller, now, there was a paper about motivational interviewing back in 1983. Are you the guy who wrote that? I said, yeah. I'm amazed that somebody read it. I didn't really think many people would see it. And he said, not only have I read it, I'm trying to teach this method because due to that paper, this has become a preferred method for addiction treatment in the United Kingdom. And I'm going all up and down England and Wales and Scotland and Ireland and teaching this, and I don't even know if I'm doing it right. You need to write something more. So I said, well, show me what you do. And we had lots of conversations and role plays, and he understood exactly what I had been writing about. And he had the same heart. And I said, look, let's write a book together. And that's where the first edition of Motivational Interviewing came from, which is now, now in its third edition. Let's see, can I go back? No, okay. Now, if you open up Google Scholar, which will look for articles on any particular topic, and you enter motivational interviewing, the exact term, you'll now find 100,000 hits. It's just astonishing how much this is being written about. And there are now more than 1,200 controlled clinical trials of motivational interviewing around the world in a huge variety of nations and settings. There's so many clinical trials that are more than 100 meta-analyses and systematic reviews of motivational interviewing in the literature. It's being used in a lot of different fields that I never envisioned it would go into. We now have more than 3,000 trainers in an international motivational interviewing network of trainers, and that's why I'm in Tallinn today. That group is meeting here in Tallinn this year. And you have a wonderful array of trainers of motivational interviewing in Estonia. And I know this is being taught and practiced in at least 55 languages around the world. Now that astonishes me, you know. But it started with alcohol problems. That's where it began. So the oldest literature is with helping people with alcohol problems. Well, what is this? It's a person-centered or client-centered way of counseling that's designed to evoke the person's own motivation for change and their own commitment to change. So rather than saying, I have what you need and I'm going to install it into you, I say, you have what you need and together we're going to find it. Now, my training in behavior therapy was the former. I have all these cool skills and you don't have those skills, and I'm going to teach you those skills and then you'll be better. Or in cognitive therapy, your thinking is irrational, my thinking is rational, I'm going to teach you rational thinking, you know. Or I have insight and you don't have insight and I'm going to give you insight, you know. All of those are I have the answer for you kinds of methods. Motivational interviewing is kind of the opposite of that and tells what I think is the truth, that the client has the answer to how to do this. We now teach it as having 4 processes. First of all, engaging. Form a relationship with the person, a trusting relationship. And in a way, the question underneath the engaging process is, can we walk together? Can we take a journey together? Will you trust me to be your companion on a journey? Huh? And those skills are the skills that Carl Rogers taught. Then focusing. What are we doing together? The question there is, where are we going? What are the goals? What are the changes that you would like to see in your life? And with the focus in place, then we go to what is the most unique about motivational interviewing, which is a variety of skills for evoking from the person their own arguments for change, their own ideas about change, their own motivations for change. And when there seems to be enough motivation to move forward, and only then, do we begin planning. Say, how are we going to get there? How will we go there? Often still, American treatment programs in mental health and addiction jump right to planning in the first session. Here's the plan, here's what you're going to do, we've got the solution for you. Missing what are 3 very important processes along the way. Well, Steve and I started teaching that in 1991. actually little Steve well before that. And when we watched people doing what we taught them to do, we were horrified. It just felt wrong. It wasn't what we had in mind. It was like they were trying to use techniques on people or trick people into changing or outsmart people or something like that. And that wasn't their fault. That was our fault. It was something that we missed in teaching. And we discovered what we had missed is the underlying spirit of motivational interviewing, the mindset and the heart set with which you practice. And now we describe that as having these 4 components. First of all, it's collaboration. Now, it's not that I'm an expert and I'm going to fix you. It's 2 people who have expertise having a conversation about change. You know? Acceptance, very important in Carl Rogers. It's an interesting thing Carl Rogers discovered, that when you feel unacceptable, you're unable to change. And when you experience acceptance as you are, it becomes possible to change. Now, I don't know why that's true. I don't know why we're wired that way. But after 45 years of working in the alcohol field, I'm convinced that it's true. That conveying to people a profound, radical acceptance of who they are frees them to change. Evoking, that is calling forth people's own wisdom, their own ideas, their own motivations, rather than trying to fix them or install things. Very important piece of it. And then in the 3rd edition, we added compassion, that the primary reason why we're sitting together is the other person's welfare, the other person's happiness, the other person's health. That's why we're having this conversation. It's not about me, you know. It's about the other person. And we added that because you can use many of the same techniques that we teach in motivational interviewing to sell products, to sell cars. I sat on an airplane next to a fellow who trained salespeople to sell jet aircraft to executives who didn't need them. You know? And what he told me about how he does that sounded very familiar to me. You know? So it's using some of the same methods, but it's using it to accomplish something that's good for me. You know? The commitment here is the prime directive is the other person's welfare. Now, at the heart of this is ambivalence. Whenever we look at changing, it's normal to feel ambivalent. You can see reasons why you might want to change, and you can see reasons why you don't want to change. When people are diagnosed with diabetes, they're interested in what they can do to stay healthy, and also they like their lives the way they've been living them, you know. Same thing with addictions, you know. And both arguments are there inside the person, right? If you advise, if you tell people what's wrong with them, and you tell them how to change, the client's normal response is to defend the other side of their ambivalence. You have a serious drinking problem. Oh, it's not really that serious. Well, yes, it is. I mean, look at this. You know. But I don't drink more than other people do. You know. Well, look, what you need to do is quit drinking. No, I really don't need to do that. What you're doing is acting out the person's own ambivalence, but you're giving them all the wrong lines. You're taking all the good lines, yeah, and causing them to argue against change, which literally causes people to talk themselves out of changing. Motivational interviewing helps people talk themselves into changing. Well, nice ideas, but does it work? Well, it's very clear now that motivational interviewing is more effective than giving advice and more effective than doing nothing. So if you're going to see somebody for an intake evaluation or an initial visit, if you do this, you've given them something that's likely to help them, even if you can't treat them immediately, but you've done something that's likely to benefit them right away. And certainly more effective than doing nothing. Also in healthcare, if you're a physician, you're sitting with somebody that keeps coming in with gastrointestinal problems and you think, I really think drinking is a part of this. Doing nothing does nothing. Doing even 10, 15 minutes of motivational interviewing in that context can produce a change in that drinking. So there are 26 systematic reviews and meta-analyses just with alcohol and drug problems with motivational interviewing. Usually it's one session, a single session of motivational interviewing, and they find small to medium effect sizes on average with a lot of variability. If you like odds ratios, in general, the odds ratio of the person decreasing their drinking is about double, having had a conversation like this or not. It works in primary care, it works in emergency departments, it works with college students. I wasn't sure about adolescents, but when we did our first study with adolescent substance users, none of whom came voluntarily to treatment. They were all dragged by the ear through the door by parents or the courts or something. You know? When we did our first study of motivational eating with adolescents, we got the biggest effect size we had ever seen. And in truth, adults often don't listen to kids. It is a unique experience to be listened to well by adults. Also works for smoking, also works for gambling. Just give you two quick study examples. Nick Heather's study assigning hospital patients in Australia to just get a single 30 to 40 minute motivational interviewing session compared with a longer course of teaching them skills for self-regulation or treatment as usual. 6-month follow-up, and up is good here. So this is the percentage of reduction in drinking, so higher is better. And the biggest improvements were in the motivational interviewing group compared to the skill training group or treatment as usual. Study by Peter Monti in the United States in the emergency room, where this is being used a lot now, with kids, with adolescents coming in intoxicated and injured. Comparison to standard emergency room care. The MI condition is a single session, again, of about half an hour, 40 minutes or so. And realize often this is in the middle of the night with a kid who's intoxicated and injured and has just been stitched up, and it doesn't seem like your optimal conditions for psychotherapy, And yet, big reductions at 6 months in self-reported drinking and driving, not as much as you would hope. Big reduction in moving traffic violations. Big reduction in repeat injuries. One of the reasons that emergency room physicians want to do this is if people come in with an alcohol-related injury, they're likely to come back again with an alcohol-related injury. And doing nothing about their drinking didn't seem ethical, so let's try something. All right. Second common finding, again, surprised us. When you compare motivational interviewing with longer interventions, usually motivational interviewing is just as effective as a longer treatment. Didn't expect that to be true. Here's Project Match, 1,726 adults across 9 different sites in the United States, aftercare and outpatient, randomized clinical trial to 3 different treatments, either motivational enhancement therapy, which is sort of a fancy version of motivational interviewing with some assessment feedback, or 4 sessions, or 12 sessions of cognitive behavior therapy, or 12 sessions of 12-step facilitation, encouraging people to get into Alcoholics Anonymous. 15-month follow-up. Here are the data. This is percent days abstinent, going from about 30% on average, so drinking on 70% of days, up to 80 to 90% days abstinent, and really no differences among the 3 treatments over that time. In fact, at 3-year follow-up, they still weren't different from each other. They repeated the study in Britain using a more intensive behavior therapy, and again, no differences between a short motivational interview and a longer behavior therapy. So this is a pretty consistent finding. Third, if you deliver motivational interviewing early in treatment, it tends to substantially improve the outcomes of treatment, of the very same treatment. So just adding a single kind of motivational boost at the beginning, which is what I had in mind in the beginning, really does seem to improve the effectiveness of drinking, of treatment. For example, here are 3 different alcohol treatment programs: an adult outpatient program, an adult inpatient program, and an adolescent outpatient program. This is percent abstinent 6 months later, and it tends to be about double or so. I mean, the very same program, all the patients are getting the same thing. The only difference is whether they had a motivational interview at the beginning or not. You know? And the treatment program is almost twice as effective with motivational interviewing up front. Related to that, when you add motivational interviewing to another effective treatment, they both work better. The effects last longer, and the effects are bigger. This is a meta-analysis, and the main line of interest is this one. This is the effect size of motivational interviewing when it's being added to something else that's effective. And what you see is the effect does not go down over time like it does with motivational interviewing alone. So it makes sense to combine this with other things that you're doing. And while motivational interviewing by itself will have an effect often, it's not as good as combining it with something else that works. And that's the most common use of motivational interviewing now. In clinical trials that are appearing, motivational interviewing is being mixed with lots of other things: pharmacotherapies, behavior therapy, psychotherapies, just all kinds of things. And in a way, what we're discovering is that motivational interviewing is a way of doing what else you do. If you're a diabetes educator, it's a way of doing diabetes education. If you're an addiction counselor, it's a way of doing addiction counseling. And it doesn't mean you stop doing what you've been doing before, unless what you were doing is shouting at people and confronting them. But you don't give up the other things you're doing. You simply combine the two, and they both work better. Now, the last thing I want to talk about is a question I had about treating less severe alcohol problems. As you know, the Diagnostic and Statistical Manual now classifies alcohol use disorders as a single category. Why is that? Because alcohol dependence was not a distinct disorder from all the rest of alcohol use disorders. They just kind of differ from each other in severity of dependence, severity of problems, severity of physical impairment, lots of different dimensions that really aren't all that related to each other as well. So I think they made the right decision to say alcohol use disorders kind of belong in a group together. But mostly in the US, we're treating people at the severe end, people that you might call alcoholic or severely dependent, because our treatment programs are designed to do that. Alcoholics Anonymous is designed to do that. You know? But what about earlier? I really started my career trying to find a way to intervene earlier so that people don't get to the point of severe problems and losing their families and jobs and dependents and all of that. So what can you do to help people who are less severe in their drinking problems? Right? It turns out that people with lower severity alcohol problems or dependence are more likely to moderate their drinking than to abstain completely. If they're going to be successful in changing their drinking, they're more likely to do that. People with more severe problems are more likely to abstain, to succeed by abstaining, than by trying to moderate their drinking. I did 10 years of research trying to help people moderate their drinking, and we learned a lot from it. More people who came into our program to learn to moderate their drinking quit drinking than continued to drink moderately. Now, some did continue to drink moderately over time, but quite a few. When we went back and followed them up a year or 2 or 4 years later, they had stopped drinking. And it wasn't for the reason I thought it would be. It wasn't because they tried moderation and failed. It was because they tried moderation and succeeded and said, this is hard. I feel like I could fall off the tightrope at any moment here. I mean, I'm just struggling, white knuckle struggling constantly not to drink too much. And the other thing they told us was, what's the point in drinking so little? So people at the high severity end decided that moderate drinking was pointless and gave it up. Well, that's fine with me too. Lots of other people drank moderately and didn't progress to more severe levels. So offering that is an interesting option, and particularly offering it with people with lower severity, I think is the place where it really belongs. Now remember also that people coming in to get moderation training, working with a therapist, had the same outcomes as those working with a good self-help book. So it's not that you even have to bring people into therapy and do a lot of therapy with them. In fact, what makes sense is give them the methods for changing their drinking, come back and see them in 10 weeks and see how they're doing. If they're not doing well, now you can see them and you can work with people that are struggling more. But if they're doing fine, you've saved a lot of treatment dollars there as well. So in summary, we were originally developed motivational interviewing to treat alcohol problems. That's where the biggest literature is, 26 systematic and meta-analytic reviews. Usually the length of motivational interviewing is between 1 and 3 sessions, so it is not a long-term treatment. It is more effective than just giving advice or confronting people or doing nothing. It's just as effective on average as longer treatments. It significantly improves outcomes when you add it to something else that works. And it combines very well with other treatment methods, which is why I say it can be a way of doing what else you do. You can combine it with nicotine substitution if you're trying to help people stop smoking. You can combine it with a 12-step approach. You can combine it with behavior therapy or cognitive therapy. You can put it together with whatever else you do with helping people to make changes in their lifestyle around diabetes or heart disease. It's just a way of doing that is not pushy, is not advice giving, but is collaborative, is accepting, is evoking, is compassionate. And it can be used certainly to treat less severe alcohol use disorders. So just a couple of cautions. There's a lot of variability in outcomes. So some studies, including one that I did, found no effect at all of motivational interviewing. Interesting why that happens. But about 2/3 of studies do find a significant effect. The method is, in a way, is simple. It sounds simple as I present it and learnable, but not that easy. When you begin to try to do it, even like Carl Rogers' good listening skills. I mean, it looks easy when you watch Carl Rogers do it, and then you try to do it yourself and say, oh, there's actually more to this than I realized, As with any complex skill, proficiency requires more than reading about it. We had a reading about it and watching videotapes control group in one of our training studies. People did not get any better at motivational interviewing by watching tapes and reading books. I also made the mistake of evaluating my own 2-day workshop, and got practice samples from people before training and after training. And there was very little evidence that I had been there, Their practice didn't change that much, but they thought it had. They said, we love motivational interviewing, we're doing it now with all of our clients, but there was no evidence on the tape that they were actually doing it. And they were significantly less interested in learning more about motivational interviewing. And I said, well, why is that? They said, well, because we already learned it. So training this is a little bit tricky. It takes some feedback and coaching, just like learning a sport, just like learning a musical instrument. It's easy enough to lay a violin on your shoulder and draw the bow across it and get a sound. But starting to sound good usually takes a little coaching and a lot of practice. There's extensive research on not only the effectiveness of it, but how to learn it, how to teach it, how to make sure that it's happening. And people's self-reports of their proficiency at motivational interviewing have a zero relationship to actual competence. You know? So if you want to hire somebody who knows how to do motivational interviewing, don't just ask them, do you know how to do motivational interviewing? Have them show you. You know? It's what we do with lots of kinds of occupations. So I think I've finished a bit early and gone through quite a lot of material, including the early history of motivational interviewing, given you the bottom line findings of research. And one of the things, a motivational tip I will give you when you're teaching is never compete with lunch.
Thank you, Professor Müller. We are very well in time now.
Are we? Okay.
So excellent. We have time for questions. So if there are a few questions,
happy to take a few.
To take them
questions
now,
or comments.
So please. I think it was very encouraging what you're doing.
I hope so.
I think an excellent overview. As far as I could remember, I've never studied this method. I know a few things about it, but not thoroughly. It's used very widely in the world.
Amazingly.
Yeah.
Yeah.
So perhaps what I would like to, perhaps you could comment a few more words about combining it with different approaches in a way. So you add on to the motivational interview and add some pharmacotherapy or some other psychotherapeutic interventions. So what would be the preferences, or what can I say?
The biggest difference might come when the person is not doing what you've encouraged them to do. They're not taking their medication, they're not doing their homework assignments in behavior therapy or whatever. And the usual approach to that is persuasion. You know, so no, it's really important to take your medication. I really want you to take your medication. This would take more of a listening approach and problem solving with the person. How could you actually get that done? Or maybe this was not what you wanted to do. Maybe we need to find something else. Good listening. Many behavior therapists are not particularly good listeners, I find. And if there's an evidence-based treatment in the alcohol field, it is good listening. And that empathic skill is something that, no matter what the kind of treatment is, improves outcomes. So the book I'm working on now is what is it that makes a good therapist? Because within any kind of treatment, you get huge differences based on who's doing it. And one of the things that matters is empathy, is this skill of listening. So you would be doing the same treatment, but doing it with more listening and interest in the person's own experience and paying attention to what they're experiencing. Joining rather than advising and persuading and so on. But it is literally just a different way of doing behavior therapy or cognitive therapy. And when I have watched senior behavior therapists doing treatment, they do a lot of this, but they don't write about it. They don't talk about it. Yeah.
More questions?
Over here?
Yeah, I see the microphone about to arrive.
I have a short question. Do you believe that someone can be really trained in the field, or it takes more of the personal empathy level to become a good?
Both things are true. I mean, we've trained lots and lots of people. So yes, you can learn to do this, and you can get much better at it. If you have a head start, you're already a good empathic listener, it's a lot quicker. So when I had to train a lot of therapists for a big clinical trial, I had them first demonstrate their ability to listen empathically the way Rogers taught. And it was much easier to teach them motivational interviewing. Because in a way, that good listening is one of the hardest parts. And if you haven't learned that yet, that's the first thing to master. And it's hard to do the rest of motivational interviewing until you're pretty comfortable with and pretty good at doing reflective listening. Yeah. So yes to both.
Thank you.
Aitäh ettekande eest. Et oma ettekande keskel te ütlesite, et siis kui te hakkasite tegema koolitusi, siis te märkasite koos Steve Rolnikuga, et see tulemus polnud üldse see, mida te olite mõelnud, ja te jõudsite järeldusele, et seal puudus emmi vaim, spirit, I mean. et üldiselt Eestis meil tehakse ka vist 3-päevaseid koolitusi, millel on jätkukoolitused ja mu küsimus on see, et kuidas te selle probleemi ületasite?
Well, it first of all was a shock. I mean, I was embarrassed and, I thought my training was great and gee, there's no effect on the outcomes. Now, I don't know why I thought that, because lecturing clients for 2 days, I wouldn't expect them to change their behavior, and so what it did was to raise good questions. So what does it actually take to get good at motivational interviewing? And we tried the 2 things that help any complex skill, which is feedback of your performance and coaching. And either one of them helps, and both of them together help a lot. So our problem was kind of implying to people that at the end of the workshop, now you've got it. And so I no longer do that. I say at the end of the workshop, you're beginning. Your learning process begins now, and you will learn from practice, but you'll learn better from practice if you are sharing that experience with someone else who observes you. If you get somebody that can coach you a little bit occasionally, and it is just like learning a musical instrument. You can sit by yourself and practice, but usually people who are good teachers know certain things they can teach you that will speed you along the way. So it's like that. So yes, it was not a finding that I enjoyed the first time it happened, but it raised the good question, the better question of what does it actually take to develop clinical skill in motivational interviewing. And we now know more about that, I think, than we know about how to develop clinical skill in behavior therapy or cognitive therapy or psychoanalysis or anything else, because we have this huge literature on training, including randomized trials of different training methods. So we're getting pretty good at being able to help people learn this. There still are 2-day workshops around, but even if I teach them, that by itself will not be enough. Yeah.
Well,
There's one here.
oh yes, the microphone.
Tundub nõnda, et see esimene samm on kliendi usalduse võitmine. Kui suur on erinevate klientide puhul see aja erinevus ja kas on ka selliseid kliente, et ei õnnestugi seda usaldust ja siis ka ülejäänud ei õnnestu?
Well, how long does it take is an interesting thing. If you watch motivational interviewing sessions, remember we're talking mostly about one session, So it's not like we're building trust over 35 sessions in time. Mostly it's a short-term intervention. But you can almost see the moment where that trust begins. And one of the videotape examples that I did, I was counseling someone who was sent to me to talk about his drinking. And he wasn't happy to be there. And he started off saying, I don't think drinking is a problem for me. I think smoking is my real problem. And my first reflection was, so alcohol hasn't caused any difficulties for you? To which he said, well, no, anybody who drinks as much as I do is going to have some problems, And so we kind of went back and forth, and along about 2 or 3 minutes, he says, you don't know anything about me, do you? I said, no, I specifically asked not to be briefed about you because I want to learn from you who you are. He said, oh, well, let me tell you my story. And he literally leaned forward, and from that moment, we were collaborating. And often there is that kind of moment of join up, that moment of, oh, you're not going to criticize me. You're not going to tell me what to do. You're not going to be an expert and try to fix me. We're actually having a conversation here. And so it can happen relatively quickly within a motivational interview. Now, if you're doing longer term treatment, yes, of course, there are people that it takes a long time to develop trust with. I know that as a therapist as well. I'm talking about within the research confines of motivational interviewing, that the trust that you see emerging within the early minutes is often enough to get momentum going. So these are not things I expected from my psychotherapy training, but I was in denial. I had to admit that I was finding what I was finding. Yeah. Okay.
Yep. Microphone, please.
I have one question. Do you use any icebreakers, they call, when you get to that point that person doesn't want to talk a lot, so just to change the subject, or what do you do then?
I'm not an icebreaker person, actually. and chat, just kind of talking about stuff, is not associated with better outcomes or better engagement from the research that I know. I sat down in front of a television camera with a client that I'd never met before, and I knew that my goal was just to demonstrate reflective listening. That's it, And 15 seconds later, I was saying, great, I'm supposed to demonstrate reflective listening, and I got a client who won't talk, But I was reflecting his posture. I was reflecting what he was sort of telling me non-verbally, just in little bits, and he would say a little bit more, and I would say a little bit more. And over the course of about 15 minutes, he was talking more than I was over that time. So I have learned to trust reflective listening. Now, you will certainly have some clients who just refuse to say anything, so I don't have a solution for that. But rather than trying to find something friendly to talk about or whatever, I'm interested in acknowledging the fact that this human being is here and sitting with me, and what's going on in this conversation. What's happening? He clearly was unhappy about being there, and I reflected that, and that someone has told you you have to come here, and so he began to tell me a little bit of that story. So patience is important. In some of Carl Rogers' demonstration tapes, there are 20 minutes of silence. Now, I don't recommend that, But he was a very patient man, and he was sitting with schizophrenic patients and just sort of kind of waiting for something to emerge, and it would over time. Yeah. But no, I don't have any icebreaker tricks, no.
No niin.
Lunchtime.
Yes,
All right.
lunchtime. So.